I assure you, I don't think today it will be quite as long as the 4-hour sessions we have previously had. So today will certainly be our fourth meeting now. I think we, by the end of today, would have heard from at least 37 different agencies coming here. And I continue to say that how much we appreciate what everyone's already doing in this world. And I know the commissioner's very familiar with a lot of the programs, but I think a lot of us have learned a lot from hearing what people are doing throughout the state. So certainly do appreciate that. Ms. Diane Harper, thank you always. Every meeting she's had our booklets up here, and these are going to be key for us as we begin to go into an executive session this afternoon at the close of this hearing, so that we can formulate the state plan as the HJR requires us to do, and then certainly hope that we can get that completed fairly quickly, at least midway through the session. And then we certainly look at a potential appropriations bill during this session. So with that said, we do not have any presentations up front, and we'll start right into the hearings. Mr. Co-Chair, you have anything?
I'm good, sir.
All right. First up is UAB Health Systems. If you'll just introduce yourself as you come to the mic.
Thank you so much. My name is Dawn Bulgarella. I'm the Chief Executive Officer for the UAB Health System, and I'm going to be tag teaming this presentation a little bit with my counterpart, Dr. or Dean Agarwal from the School of Medicine here at UAB. I've got a little bit of a cold. My husband will tell you my voice doesn't typically sound this sexy, so we'll get into this morning. If I do my job right at the beginning of this presentation, I want you to walk away with 3 key points. I'm sure that everybody on this panel has some familiarity with UAB. You've been there, you have a family member that's been there, or you've had trouble getting in, or something along those lines. But I want you to understand when you walk away from here that UAB is the leading academic medical center in the state of Alabama. We are running one of the largest hospitals in the country, and we are truly taking care of some of the sickest patients in this country. We are partnering with other hospitals throughout the state, and I'm going to share a map with you to show you those partnership relationships. And a key tagline that we like to say is that we are wanting to treat the right patient in the right facility at the right time. And that does not necessarily mean every patient coming to Birmingham, Alabama. And then lastly, even for those that we don't have affiliate or partnerships relationships with, that we are strengthening the rural hospitals in the state of Alabama such that patients can remain in their communities and get the highest level care in those facilities, which is where the patients want to be. And certainly from an economic perspective, it's where the hospitals and those city leaders want those patients to be. So I think everybody knows that UAB is a really large hospital, but this map gives you a pretty good sense graphically of our statewide network. In the Birmingham community, represented by the green dots, we are 3 hospitals: University Hospital, Callahan Eye Hospital, and then Medical West, a facility that currently resides in Bessemer and has recently received funding from the USDA to be relocated to the McCalla community. For what you may not be aware of, this is the 2nd largest USDA funding in history to help us relocate this hospital to McCalla. In the Montgomery area, we have 3 hospitals there as well: the Baptist Health System, Montgomery South, West, and Prattville. In the Birmingham area, we represent about 55% of the market, and in the Montgomery area, we represent 70% of the market. We affiliated with the Ascension St. Vincent's Hospitals back in 2020, and we added 5 hospitals for which we are responsible for. And then you can see other areas of the state. The gold bullets represent hospitals that we are managing, several of them located in smaller rural communities. We have a recent relationship with Mobile Infirmary, really specifically focused around growth of cancer, and again, the ability to keep cancer patients in their local community, sending those patients to UAB only when care cannot be provided there. And then lastly, have a very strong collaborative agreement with the Huntsville Health System in the northern part of the state. All of this with the intent that no patient, regardless of resources, should have to leave the state of Alabama for high quality care. If you don't affiliate with UAB, and that's okay, we all equally have additional relationships that we provide for you in terms of telehealth. Telehealth from an inpatient perspective is the future of healthcare. I think when most of us as lay people think about telehealth, you think about the ability to call your doctor, I feel like I have a cold or the flu, and get a prescription without leaving home, and we certainly provide that. We provide 600,000 telehealth visits throughout the state of Alabama in every single clinical subspecialty. So look to the left there, or excuse me, to the right of your slide, teleneurology. We are providing stroke services and general neurology. In an aging population, these are critical services to the health of the citizens of the state. We provide telehealth services such that an individual can have telephonically or via computer, can have a visit with a teleneurologist around a stroke in 6 minutes, so that we can help diagnose patients that truly are having a stroke and need to be brought into a teleneurology site like UAB provides, or in fact they're not having a stroke and they can stay in their local community. General neurologists represent a national shortage area, and they're certainly short in the state of Alabama. So as all of us are aging, we at one time or another may need services from a neurologist. Nationally, only 25% of the Medicare population can get teleneurology services or neurology services at all. You can see telecritical care in ICU. We are the lone provider of ICU services in some of these rural facilities, meaning that the hospitals actually have an intensive care unit for the sickest of the sick patients, but they don't have the doctors to provide the care there. We are those physicians out of Birmingham, Alabama. We are treating patients from every county in the state of Alabama. You can see roughly 50% of our patients come from the Birmingham Metropolitan Statistical Area, and the remaining 50% come throughout the state. And if you ever have an opportunity to visit us, we'll take you to our Center of Patient Flow, which really looks like an air traffic control station, in which we are taking calls from every hospital in the state of Alabama seeking a transfer of a patient that needs a higher level care than they can receive in their home community. Well, I've said we're a really big hospital. UAB is the 8th largest hospital in the United States. We're the 4th largest public hospital in the United States. Hospitals are judged based on their size, based on licensed beds, and we are 1,207 licensed beds of tertiary care in the state. I said we take care of the sickest of the sick, so from an acuity level or patient complexity level, we currently are taking care of the 8th sickest patients in the country here in the state of Alabama, oftentimes related to illnesses that unfortunately in the southeast have a higher burden of care here. We're the 8th largest hospital in the country, and yet we are 100% full Monday through Thursday. 100% full. So if you have a need to be admitted or a family member to be admitted, it's unfortunate, but you often have to reach out and see if somebody can help you out there. We have 92,000 discharges, meaning patients exiting University Hospital, 144,000 emergency room visits, and I'll share a little bit about the emergency room visits. And we are the only Level 1 American College of Surgeons accredited trauma center, again, representing that we're taking care of the sickest of the sick, the worst trauma patients. We employ roughly 1,600 physicians in the state, and we are recruiting from every state in the country as well. U.S. News & World Reports does an evaluation of roughly 5,000 hospitals on an annual basis, and these are the results from 2023 and 2024. The hospital, University Hospital, is the #1 hospital in the state. I cannot recall when we were not the #1 hospital in the state, but we are equally one of the top-ranked hospitals in the country. Of the 5,000 hospitals that they are evaluating, they're looking at roughly 15 medical clinical subspecialties. And you can see this list here that we have some 9 or 10 subspecialties ranking in the top 50 in the country on an annual basis. We are the only national cancer institute designated as a comprehensive cancer center within a 4-state region, and that again means that you're receiving the highest level of cancer care that you can here in Birmingham, Alabama, and then most recently with our affiliation in the South Alabama region with Mobile Infirmary. We have one of the best cardiovascular programs in the country and one of the busiest transplant programs in the nations as well. From a trauma perspective, you may be familiar with this, the state is divided into 6 regions. Unfortunately, many of the areas of the state of Alabama are considered trauma deserts because they do not have a trauma center of any level within their community. And there are 470,000 residents in the state of Alabama that are more than a 30-minute drive from their local hospital. With our telemedicine programs, as we've described, we are working hard to keep the patients in the community that can stay there, but in the event that a patient does have to drive into Birmingham for the level of care that we're providing, you can imagine how long that's taking an ambulance out of that community. And in many of the smaller communities, there are 1 or maybe 2 ambulances, and so a trip to Birmingham will tie up all or half of their ambulance care for the day just by making a trip into Birmingham. So we certainly want to make sure that they need to come there. In 2022, we completed an economic impact study. We had done one 3 or 4 years prior. We knew the numbers were going to be great, but I think these are very impressive numbers. You can see the economic impact of UAB as an academic medical center, and then the economic impact of the UAB health system on the right-hand side. We represent $6.4 billion to the state of Alabama and some 57,000 jobs. For every $1 in state funding, UAB generates nearly $40 in economic impact back to the state of Alabama. And 1 in every 20 jobs in Alabama is either held directly by a UAB or UAB health system employee or in direct support of services that are providing there. It's important for you to know as well that we are providing more than $350 million in charity care to patients that come to our doorstep that have no ability to pay. $350 million in charity care on an annual basis. With that, I'm going to turn it over to Dr. Dean Agarwal, Anupam Agarwal, that heads up the School of Medicine.
Thank you, Don. Good afternoon, everyone. My name is Anupam Agarwal. I'm Senior Vice President for Medicine and Dean for the Heersing School of Medicine. Truly appreciate the committee's time in giving us a chance to make a case. You just heard from Don, our CEO, the extent of our healthcare across the state. Walk you through some of the proposals we've developed for addressing the opioid epidemic. So what we did was, to make sure we put the best proposals to your committee, we had an internal competition across UAB. We received over 35 proposals. We had a committee that we developed internally, and they scored each proposal from 1 to 5. And based on those scores and based on thematic areas of relevance to this committee and the guidelines that you all had put forward, we want to present 5 proposals to this committee. So give you the little background, Don showed you the extent of healthcare across our state, that almost every county we get patients at UAB. This heat map here just shows you that healthcare providers across our state have the knowledge and resources needed to treat opioid use disorders. And you can see here, this is a graph, obviously about 40% of the patients are from Jefferson County, but these are patients over a 5-year period that were treated for opioid use disorder in these from 2016 to 2021. You can see almost every county across our state have been seen at UAB. So our proposals are over the 3 thematic areas: education and training. We have 2 proposals: educating Alabama's healthcare workforce, investing in medical education; prevention, reducing opioid reliance following surgery; extending the comprehensive addiction in pregnancy program, or called the CAP program; and a treatment proposal, treating opioid use through a statewide interdisciplinary health network. So the first proposal pertains to educating Alabama's healthcare workforce. So the goal of this is to really ensure that our healthcare providers in our state are educated based on evidence-based approaches to treating opioid use disorder, and also to be aware of non-opioid pain management. We have a very extensive curriculum at the medical school level, both in the preclinical years and the clinical years, that extends to addiction, pain, opioid, non-opioid management of pain. So that is extremely extensive. But this is for our existing healthcare workforce. So what this proposal will do is facilitate in-person learning session as well as online mini lectures with clinical educators across the state and through our extensive provider-based network that Don just shared with you about. It'll incorporate opioid and addiction education at all levels of the healthcare training through our state in partnership with our statewide health education centers, or AHECs, that we have established and funded through HRSA, and other programs so we can reach also high school, college, professional schools, as well as providers. The second proposal is to treat opioid use disorders and managing chronic pain, again through a statewide interdisciplinary health network. And the goal here is to build clinical capacity across the state to treat opioid use disorder and to reduce inappropriate use of opioids for chronic pain. So what we want to do is expand access to care by utilizing telemedicine and affiliated clinics, as well as mobile clinics across our state through existing networks and partnerships. And you saw that statewide network that Don showed you that is already in place. And we have telenephrology, tele-ICU, telestroke, teleneurology, telecardiology, so multiple specialties. So the goal is here to use that existing network to incorporate addiction and pain medicine through telemedicine. So really providing clinical care for the most complex patients using the stepped care model. So where you have self-care, primary care, secondary consultation, and subsequently tertiary care. So this is a stepwise education tool that we hope to implement across the state to address opioid use disorder. The third proposal is to reduce opioid reliance following surgery. So we know that most patients post-op for pain control end up getting prescribed opioids, and those are the patient population that are most susceptible to getting addicted to opioids. So we want to establish a transitional pain service at UAB for complex patients that have increased risk for opioid reliance after surgery. Provide them with evidence-based educational practices and materials designed for these patients to reduce the demand on opioids and lower addiction risk after surgery. Expand a program called the Standard Enhanced Recovery Program, which has been shown to reduce opioids following surgery, and to develop standardized protocols for patients post-discharge in terms of how they utilize opioid prescriptions. The next proposal is extending the Comprehensive Addiction in Pregnancy Program to 12 months postpartum. So this is an important program for mothers and infants as well. So currently the CAP program is limited and it ends at birth of the child. So what we're proposing is to extend this program to 12 months postpartum. This would curtail substance abuse postpartum. It would reduce overdose events in mothers to newborns and infants who really need a parent, and reduce maternal mortality due to substance abuse disorder. And finally, investing in medical education. As I said, we have great programs at the medical school level, but a huge need is for residents. So this program would bolster our healthcare workforce to address the opioid epidemic. What we hope to do is establish 19 additional slots per year in addiction medicine and psychiatry residency programs. And this would be across the state in Huntsville, Tuscaloosa, Birmingham, and Montgomery to increase the physician workforce to address opioid disorder. Currently, there's a shortage of about 250 psychiatrists needed for our state to address the mental health challenges that we face. 40% of them are over the age of 60. So clearly there's a huge need for psychiatry residency programs. And it's been clearly established that where you do your residency determines your likelihood of staying in that area to practice medicine. So 60 to 70% of physicians that complete residency will practice within 100 miles radius from where way they did their residency. So really a goal of this program is to establish these residencies so they'll practice in regions where they do their residency programs. So the Addiction Medicine Fellowship is about a year, and the Psychiatry Residence a 4-year program. Currently, we have only 2 addiction medicine and 2 psychiatry programs in the state, one at UAB and one at University of South Alabama. With that, I'll be happy to answer any questions, and Don can join me as well.
Thank you, Dean. I appreciate it. Is there also some federal dollars that are tied to those residencies?
So not initially, but the hope is that down the road, once the residency programs get up and running, you could hopefully get GME-funded slots. There are about 1,200 slots that were approved across the nation. Unfortunately, we got only 2 of those last year, and that is across all specialties, not just psychiatry. So one of the goals is how can we sustain this program, is to tap into the GME-funded programs, in subsequent years.
Yes, sir.
Yeah.
Any question from commission members? Yes, sir.
Thank you for the opportunity to speak, Mr. Chairman. I'm having a brain fog. I just want to express my gratitude to UAB. I represent Selma and the Black Belt area, and your residence program is just so impactful. I just want to ask about your transitional pain service, and I understand I just want to ask about how do you all determine who has an increased risk of excessive opioid reliance?
Well, a lot of it is, that's not my area in particular. I'm a nephrologist or a kidney doctor, but we have experts who deal with that on a day-to-day basis. We have a center specifically for addiction and pain medicine. So I would leave it to those experts to figure out. But a lot of times, just from my general knowledge, it's a history. If someone has had previous history of opioid use disorder, those are the ones very likely to come back with opioid use again in subsequent hospitalizations or when they have the symptoms. So I think education is really critical in that regard. So I think that is one clear factor. The other things are other social determinants of health. Do they have adequate access to healthcare resources, to food, nutrition, diet, primary care access, some really fundamental needs, really help it understand who is likely to, become dependent on opioids or not. So.
Commissioner.
Just a couple of questions. We know from evidence-based practices that involving people with lived experience is really very helpful in these situations. I didn't see any reference to that in your proposal. Is that part of any of the projects that you're proposing to involve people with lived experience?
No, absolutely. In fact, our Center for Addiction and Pain Prevention includes patient groups that are critical to the success of any program for that matter, not just addiction,
right,
but any program. The success of the program has to be the patient group and the patient voice, because if somebody who's gone through opioid use and is successfully, rehabilitated, they're the ones who can be the most powerful voice. So we engage them at all levels, and everything we do, within our health system too, we engage the patient, even in terms of redesigning our emergency room, for example. The patient voice is really critical in that regard. So.
And my other question, I know in Mobile, the residency program there partners with Alta Point, our community mental health center. I was curious about your Huntsville program and whether there was a plan to partner with Wellstone in Huntsville.
No, absolutely. None of these programs will be standalone and will succeed without partnerships with critical, including, folks within the state as well. So.
Mr. Davis.
First of all, just to...
I was going to say as well, the Alta Point relationship, we are looking to, can we further that in the Birmingham community at both UAB and Medical West as well? Mm-hmm.
First, heartfelt thanks, and I mean this sincerely. My wife and I are both stage 3 cancer survivors, and I think it's because of the care we got through the UAB system, and I mean that sincerely.
Thank you.
And then a question for you. You talked about populations that are uniquely affected by the opioid crisis. Last meeting, I spoke about the impact on the veteran community in Alabama, disproportionate impact. One of the frustrations I face is the federal VA is woefully undermanned in their mental health services. And just last week, I was in a teleconference with UAB and federal VA trying to establish one of those residency programs, but they just don't have the personnel even to support a residency program. Do you have any tailored programs specifically for veterans in the UAB system? And I understand it's not your area of expertise.
So we are lucky that our Birmingham VA is physically connected to UAB Hospital. So that's a big advantage for us. We have some very senior investigators and physicians who practice at the VA whose specialty area is addiction medicine. Stefan Cortez is one who comes to mind. He has spoken not only to the VA leadership in Washington, D.C., but at Congress as well, in terms of the importance of expanding, education and other tools to address the opioid challenge. So we are clearly, what we do, through this will clearly expand into the VA, health system across the state as well.
Good.
So.
Thank you.
Representative Moore.
Yes, I was looking on here. It says that Alabama currently only has 2 addiction medicine fellowships and psychiatric residency programs. I know representing part of the Huntsville community and Dr. Martin up there, who works with y'all as in the department over there in Huntsville, he was very interested in trying to get that program started. And would some of this be used to try and help bring something up there to the Huntsville area as well?
Absolutely, absolutely. Yeah. In fact, that is one of the rationales to, move that proposal forward as well. And we have full support. As you know, Dr. Martin is part of our faculty. Huntsville is one of our regional campuses for the Birmingham, Hearsing School of Medicine. So we are committed to that program as well, for sure. So.
Thank you very much. We certainly appreciate what you're already doing for Alabamians. Appreciate it.
Thank you. Thank you.
Next up, Auburn Center for Opioid Research, Education, and Outreach.
What? Okay, good afternoon, members of the commission. I certainly appreciate the opportunity to speak to you today. My name is Brent Fox, as you can see. I'm a faculty member at the College of Pharmacy at Auburn. I'm also a founding member of our Center for Opioid Research, Education, and Outreach, which we affectionately call COACH, and we can revisit the foresight or not of calling it COACH, but we can come back to that later. Before I begin talking about COACH, I want to spend just a brief minute talking about Auburn and the College of Pharmacy. So Auburn was chartered in 1856 and is one of the original 57 land-grant universities across the country. As a land-grant institution, our mission is to address local needs or local issues or local opportunities using expertise that members of the colleges and the universities at Auburn, colleges at Auburn have. So prior to the pandemic, the number one public health issue in our state, and really all states, was the opioid epidemic. So prior to the pandemic, that was our number one issue. The pandemic diverted our attention, of course, and diverted our focus, of course, but the opioid problem is still there. And as we are here today and in other events that we participate in, we know that it is still a major issue in our state. So that's kind of some background. The College of Pharmacy was established in 1885. We're the only public college of pharmacy in the state, and we embrace the university's, heritage and mission as a land-grant institution focused on the state's needs and opportunities. So because of that, we want to serve our folks in the state. I'm originally from Alabama, so I'm also passionate about this as well. So hopefully I can paint a picture of the work that we have already done and been doing in this area for multiple years and provide a future look, if you will, into what we would like to do with the funds that we are here to talk about today. So as I mentioned, COACH, you can see what the acronym stands for. I mentioned we were founded in 2019. So while we were founded in 2019, we had individuals in our college who were working in this area, the opioid area, for years before that, but the formal establishment of the center was a significant and symbolic, I guess, event in our college's history to indicate that we're going to pull our resources, pull our expertise, pull our personnel together to focus on this problem. So I believe I've watched some of the recordings and some of the live events that y'all have had, and I know y'all have talked about the opioid epidemic in these three buckets. And I think it's important to think about those three buckets. What we do in our center is provide education and outreach across the three buckets. Now, we could argue which bucket is the most important. And I think whichever bucket you may fall in, you probably have a good rationale. I mean, they're virtually all important. I have children that are 8 and 10. Prevention is really important to me with children that age. I have friends who are in treatment and recovery. So from that perspective, treatment and recovery are also very important to me. But what we try to do within our efforts within the center is provide education and outreach across the three buckets. So over the last 5 years, we've secured roughly $4 million in funding from external sources to provide these education and outreach events throughout the state. And I'll show a map later to kind of lay that out for you. So I know that y'all have heard and you're familiar with the data on the problem, so I don't really want to talk about the problem and rehash, which I've already talked about, but instead what I want to talk about is how we've approached it and the work that we've done. So the question I would ask myself, was who needs to know about the risk of opioids in our state? Who needs to know? And I could have just put everyone on this slide and been done with it, frankly. Everyone needs to know. But that's not very colorful, and I like colors. I'm a visual person, so I thought, what groups need to know? And certainly in these groups, there are subgroups. For example, EMTs, they may be parents. They may have some other background that they came into that profession with. But my point of this is everyone needs to know, but the reasons they need to know and what they need to know may be a little bit different. So your K through 12 teacher probably needs to know about opioids from what to look for in the students that they work with, and that may be a little bit different than what a pharmacist needs to know when they're talking to a patient, or they're using resources that we have to help make decisions about patients. So maybe the knowledge is different, but the need is there across the groups that we have worked with. So when we give our educational sessions, we often use a tool that allows us to have people use their cell phones or smartphones to say what group they represent. So this is from one of our events, and I bring this to the meeting today to say, these are the people that we're talking with. These are the people that we've met with. These are the people that we have educated to try and talk about this problem throughout our state. We had a recent program that was literally last Friday that we'll talk about who was there at that. So we've been, for 5+ years, we've been building these networks within our state of trusted individuals, trusted groups, and local communities that allow us to go in and talk to individuals regardless of their need, regardless of which bucket they were on the previous slide, about opioids and opioid use disorder. So what do we actually do? I've been kind of general, but what do we do? So I'm a visual person, which I mentioned a minute ago. I'm going to go through each of these images to tell you what we do and what we propose to do. We get in our cars and we go to the communities. That's one thing we do. We drive to wherever we have an event, and we're there in physical presence to talk to people about opioid use disorder. So we have the core members of our team are in Baldwin County, Lee County, and Madison County. But our college actually has faculty in 5 regions throughout the state, and they're full-time faculty who live in those regions. So we have faculty already embedded across the state besides our core members of our team. Our college, so I'm talking about the second image, our college also has a campus in Mobile. Many probably are not aware of that, but we have a campus on USA's campus, and that campus has been there since 2007. So we have been delivering live, synchronous, so live real-time education to pharmacy students since 2007. So we have extensive experience delivering live educational events over video. During the pandemic, that was great. We transitioned, and it really helped us continue our education. We also, on Auburn's main campus, have access to a television quality studio. So that's the third image, the green screen. So depending on the event and depending on the need, we can go into a studio and create high quality training and education that can then be delivered to whoever the target audience is. So in 2022 and 2023, I just have some numbers that I've jotted down. We provided education via these three media to over 1,300 healthcare providers and 4,000 community members. So that was 2022 and 2023. But I want to talk about just a few of our programs to highlight some of what we have been able to do over the last several years. So beginning on the left, on the Opioid Training Institute, as you can see, we call it the OTI as our short term for it. We focused on delivering live in-person education to healthcare professionals and community members in 16 different events across 8 cities in our state. So we got in our cars, we drove to those cities, we provided a healthcare profession-focused event, and usually the next day we had a community member focused event. So we actually were able to do that in 12 months. We provided all of that education at those events, and that was, as you can see, sponsored by the Department of Mental Health. So they were one of our partners. The second image was also sponsored by the Department of Mental Health. And this one highlights our ability to go into the studio. So we created 13 programs that were recorded in the studio on Auburn's campus. We have now made those available on the web for both healthcare professionals and community members. And the beauty of this program, in my opinion, is that for healthcare professionals, they can go and access those programs and receive continuing education for no charge. So we provide that education that fits their needs, and there's no charge for them. The third event happened most recently, and this one was actually funded by a crowdfunding effort from Auburn. So Auburn has something that we call Tiger Giving Day in the spring. Each college comes up with an idea for something they believe can be impactful. And then members of the Auburn family, as we like to call it, we provide funding for those events. So our college proposed to provide education to middle schoolers and elementary schoolers about drugs of abuse and what to be aware of and what to watch for. So we went to different schools throughout the state and delivered in-person education to these students, 5th through 9th grades, as you can see. And we also, in the Huntsville area, were able to pull in their parents for a separate event. So as I said, I have young children, and my daughter is the 10-year-old, so she's in that age group. So that's really important to me, certainly, and passionate, something I'm passionate about. So that was an event that was, again, sponsored by the community, not really by an agency. And then our last example is something that was the most recent. So we have a relationship and a sponsorship from the Department of Public Health to deliver town halls, as we call them, and summits. So in the town halls, we bring individuals who have access to the prescription drug monitoring program, which is that's an online software database that individuals who are authorized can look at patients' controlled substance dispensing history. So you can see what the patient in front of you has received in terms of controlled substances. So we bring prescribers and pharmacists together in a small group setting with their computers, and we walk through how to best use that tool. So that's what we do in our town halls. Over the last 18 months, we've held 10 town halls. The summits are large group educational events, and the one that I mentioned a few minutes ago that occurred in Montgomery last Friday was our second summit with ADPH. So there we bring several hundred people together and address or talk about whatever issues we need to related to the opioid epidemic. So throughout our time working in this area, we've developed a lot of partnerships, a lot of collaborations, and I feel like we've built trust with our partners. This slide is not intended to list all of our collaborators, but is intended to list ones that have been recently meaningful, if you will, or recently partnered with. And to me, I think of this issue, it's a very personal issue. Opioid use disorder is a personal issue. We're talking about it in this room. We have big decisions to make, but at the end of the day, families are affected by this, and that's how I think about it. So I just want to highlight the local and national experts block, if I may. Are anyone on the commission familiar with the movie or the series Dope Sick? Dope Sick, okay. So the physician that show was based on, if you're not familiar, it's a physician from Tennessee who basically developed opioid use disorder, and it chronicled his path through that, including treatment and recovery. So he's very well known, or his story is very well known. So we had him come in Friday at our event and talk to our attendees about his experience. So he's that national expert who has that national awareness, if you will, or notoriety, and that gets people's attention. But we also on Friday had individuals from the Baldwin County Drug Court come and talk to our attendees, and that group included 3 individuals who had graduated from the drug court. So these are individuals who had opioid use disorder, were treated, and now are in recovery. They're experts in the lives that they live. And that is just as impactful, in my opinion, as hearing from a national expert. So when we put our programs together, we try to think about what is the most impactful way we can get whatever we're trying to get across to our attendees. So where have we provided events? So this map, each number represents a unique live event. So these are only our live events. If you look, we have 16 in the Huntsville area, 10 to 16 in Central Alabama, and 12 in Mobile, Baldwin County. That's a little misleading because, for example, where we have 6 in Lee County, that's not 6 in Auburn. That includes Tallahassee, it includes Smith Station, so we're not focusing solely on the large population centers. But anyway, these are where we have provided our live education events, and clearly, in the Thomasville area and that part of the state, there's more work to be done in those more rural areas. We also have our website, and this is what I alluded to in my very first slide. auburncoach.org gets traffic from people who are not just looking to learn about opioids. People who are interested in learning about Auburn's latest coaching challenge or initiative. We find them coming to our site because they send us emails and ask us. But I actually think that's a good thing because we're getting people we weren't planning to get. But we do have all of our materials on our website with access for people who want to go there and learn about opioids. And then I do want to mention the Cooperative Extension System, which is a unit within the university. And to me, they're one of the best examples of the land-grant mission of Auburn. ACES, as the acronym is called, has offices in all 67 counties in the state. And they have extension officers, as they are called, in those counties. Their responsibility is to work with the local citizens to address whatever they can that's an issue for that local county using Auburn's expertise. So Coach, as a unit within Auburn, has the opportunity to partner with ACES to expand using their existing network in all 67 counties. So what do we monitor or measure in our initiatives? My students, when I teach, my students get frustrated with me because I don't really put a lot of words on my slides. So that's what y'all are seeing is there's not a lot of words on my slides, but I'll try to walk you through the images. So for us, it's important to reach the target audience when we deliver whatever we're delivering. So we use digital marketing to allow us to say, we want to target this demographic in this county on their smartphones or their cell phones. We use that as a tool to reach our target demographics. And then, of course, we measure that when they attend our events. Skipping all the way to the right, we also ask our attendees, did we hit the mark? Did we provide what you feel like you need? And if not, what should we have done differently? The middle 2 images vary depending on the event. So the first one is supposed to indicate knowledge or education. So depending on what we're trying to convey to our audience and how we're conveying it, we measure, did we have an impact on their knowledge level, if that's relevant for that event. In the third one, the third image, we also measure other behaviors as best you can measure them through the means that we have. So for example, we had an event where we provided information about opioid reversal agents. And we asked our attendees how they felt in terms of their readiness and willingness to administer an agent after having attended one of our events. So those two middle images really are dependent upon the content, but we do address those as we're able to in our events. So what do we want to do at the end of the day? Why am I here in front of you? So we have years of experience. We have many relationships that already exist in the state, and we want to expand. We want to take what we're doing with our current core group and expand it, because we know that we can reach more people through that mechanism. There are existing resources that can be used to educate individuals to grow their skills, but those tools do not always meet Alabama's unique situation. So there's this refining of existing content or existing tools and making it reflect our unique needs in our state. And then lastly, the third bullet, if you will come from the first two, and that's to continue to grow our collaborations in the state, to then, again, grow that expansion and really meet the needs that are across our state, all the while measuring the impact of our initiatives. So with that, I want to say thank you again for your time and your attention, and I'm happy to answer any questions.
Thanks, sir. Any questions from the members? Well, I certainly appreciate my time there. I came over with CJ and really heard what you're doing over there at the pharmacy school, and certainly touching on everything that we are focusing on here. And I think that maybe you got some programs that we can expand. I guess, in fact, the day I didn't know you was doing it, the day I was there asking about education, y'all were in schools in Huntsville. So
that's right. We sure
great
were.
work.
Absolutely.
We appreciate that very much. Okay, if there's no questions, thank you
again.
All right, next up is the Alabama Council for Behavioral Research. A familiar face.
And it's behavioral health care, not research.
Okay.
Just, good afternoon, members. I'm Holly McCorkle, the Executive Director for the Alabama Council for Behavioral Health Care. And today I am going to try to be pretty brief because I know there's a lot of people on the agenda. I'm going to just tell you a little bit about my association, give you an overview of the some process and standards that can be community providers must undergo to receive certification from the Department of Mental Health. And finally, we're not going to be asking for a specific amount of money, but I will provide some recommendations that our association supports. The council is made up of 20 community mental health providers that employ more than 5,200 people, and we serve more than 115,000 Alabamians annually. Of that 20 members, 15 of my members do provide SUD treatment and prevention services. Our members, to be a member of our association, you have to be either a public or nonprofit entity, and they are all certified by the Alabama Department of Mental Health. Our members serve the majority of people receiving MHSU services through the Department of Mental Health, and it's really important to know that services have to be provided on a sliding fee scale, and ability to pay is never going to be a barrier to care. I did want to bring up that, many of my members receive state funding, and the state only invests annually about $10 million in SUD services across both budgets. Most of the services, the treatment services that people receive through the state is through the federal dollars, through the block grant, the SAMHSA block grant, or the SOAR funding. So I just wanted to let y'all know that there's really a very small investment of state dollars annually into SUD treatment and prevention services. I am not going to read about every one of my members. I know y'all have this in front of you, but I did want to see, so that I did want you to have just a little information about these agencies and where they are and how many people in the SUD, only in SUD services. Many of these organizations serve many, many more people, but just for that SUD treatment services or prevention. And this slide has community mental health centers that also provide SUD services. And so you see that asterisk at the bottom. And that's really important because there is such a high percentage of folks who have co-occurring. They both have a mental illness and a substance use substance use disorder. And so therefore these agencies can address those mental illness issues as well. Again, this is another slide with just community mental health centers that I represent that also provide SUD treatment and or prevention services. And then finally, these are what we would call our standalone members. They receive referrals statewide and provide SUD treatment and prevention services. And it's important to note that because we have this association, collaboration and working with providers that might, offer a service that one doesn't, there's a lot of collaboration between these agencies. Just a little bit about, I wanted you to see the length of time these agencies had been operating. The oldest operating member is 74 years. The youngest is 50. None of these agencies have popped up overnight. They've been very long-standing community partners. We have seen, especially when some of the SOAR dollars came out, we've seen, maybe some entities decide that they wanted to try to come to Alabama and provide services. And most of the time they've packed up and left because they couldn't, with lower reimbursement models and, lack of the ability for people to pay, they really couldn't make the business model work. And so I wanted to just reiterate that many of my members have been around, or all of my members have been around for a really long time and are trusted community partners. On that workforce number, that's 551 people dedicated solely to substance use disorder services. That doesn't include administrative staff. I just wanted to show that number of people that are working directly in that part of the that field. So the certification process, and there's a lot of slides, and I'm not going to go over everyone, I promise, but I wanted, when Commissioner Boswell presented last meeting, and I've attended all the meetings, I've listened, there's a lot of worthy causes, and I do not envy y'all's position whatsoever. But when we talk about certification, that can mean a lot of different things to a lot of different people. And so I wanted to give y'all kind of the code sections, and I couldn't even fit all the code sections in my slides, but I wanted y'all to be aware of just how extensive that process is. And certification ensures accountability, transparency, and sustainability. So when you're making these decisions on investing these dollars, obviously I represent certified providers, and we would really encourage you to understand that certification process and know that those organizations, there is a lot of accountability because of that process. This is a slide that it's just the number of things you have to submit an application for certification. All of this is reviewed by the Department of Mental Health. Executives have to have criminal background checks. Staff have to have criminal background checks. You have to have proper oversight, policies and procedures, and proper program descriptions. So it can't just be someone deciding, I want to start a program and open up their doors. There's really a lot of process involved in that. This chapter really governs the program operations. As you see, it oversees who's on your governing body, what type of personnel. So for example, to be an ED, a clinical director, or a business manager for a certified provider, you have to have minimum qualifications. An ED has to either have a master's degree and 5 years of experience or a bachelor's degree and 10 years of experience in the field. So these folks that are running these organizations have to have experience experience and be qualified. I thought it was really important to note that, there has to be some type of business manager or financial record keeper. So there is, I've been around the legislature for a minute, and y'all care about financial accountability and transparency. And so all of these organizations have to have folks that are monitoring the contracts, monitoring how how those dollars are spent. Again, there's policies and procedures on infection control, recipient protection, incident management. If something happens, we have to enter it in a system, and the Department of Mental Health is aware of it. If there was some type of incident in a group, in a residential treatment facility or a day program. And then there's also policies and procedures that require us to look at how is our performance and how can we improve it. And so you have to look at how are your programs going, and then try to set benchmarks and have data in regards to how they're doing and how you can improve. I thought that this was important to point out that just the physical facilities have to undergo a life safety check. And these are like hundreds of pages, just FYI, the amount of policies and procedures that we have to abide by. And, it's really important that physical facilities do maintain a certain minimum level. Plans for new construction have to be done by an architect. Those plans have to be submitted to the Department of Mental Health and approved. If there's deficiencies, if someone called and said there's an issue at a residential treatment program, life safety could go out, look at it. If it's a certain kind of deficiency, like for example, the water's not working, that has to be fixed in 24 hours. If there's other deficiencies, you might have 10 days. Others, maybe 30 days, depending on the severity. So there's timelines that these providers would have to come back into compliance, and the department has the ability to oversee that. Residential facilities, for example, that are over a certain size, they have to have automatic sprinklers. So you really have to, all of my members really have to meet a very high threshold when it comes to our facilities, which is why many times you'll hear us ask for possibly one-time dollars to complete deferred maintenance, because we have to meet certain minimum standards. Administrative review of records and for the certification. This ADMH has the right to come in and review any of our records, any of our personnel records, any of our training records. And that really does provide accountability. I remember an incident where a provider had not kept the proper records, and guess what? ADMH clawed back the money. So, they had said they had performed certain services. Then when there was a site review, they couldn't produce the records. And so ADMH was able to recoup that money from that provider. And so I just want to give y'all an idea of the types of standard, the review that the Department of Mental Health is able to do. Recipient rights protections and advocacy. This really came out of the Wyatt settlement, but there's a whole division within the Department of Mental Health that investigates incidents or complaints or issues that are submitted to advocacy that from an individual in any type of program. They can submit that to advocacy, and the provider has to cooperate with the advocacy division. So if you assert that your rights have been violated, if you assert that a group home, for example, maybe isn't in great condition, then advocacy could come out and check on that. That's, again, if you're using state dollars, you want to ensure that folks are in safe environments, their rights are protected, and there's the proper staffing and personnel. And again, these are some more specific program operation standards for SU treatment. Even personnel beyond, I listed the ED and the clinical director, but if you work in the substance use treatment field, you also have to have certain qualifications and training to work at one of our agencies. And then as you see, there are very specific standards for opioid maintenance therapy that, that providers must comply with. These are just the levels of service, and they go from 0.5, which is like early intervention and the least intensive, to like more intensive residential facilities. And I'm not going to read all these. I just want y'all to have these. So if you ever do have a question or want to be familiar with the code, the website has been updated recently and it's a little easier to navigate, just FYI. And then finally, prevention. You know, for me, I always thought like prevention's like, oh, it's like just a program. You go into a school and that's what prevention is. Well, if you're a certified prevention provider from the Department of Mental Health, you first of all have to do a community needs assessment. And you have to assess what the needs are in your community. And, you know, because as we know, different communities in Alabama have different needs. And then you have to implement programming that's based on that community needs assessment. And that has to happen every 2 years. So it's not just we're going to decide to do a program because it makes us feel good. It's based on what the community needs assessment demonstrates. And then finally, we have standards for nursing practice. We have nurses involved in many of our settings because of the type of services that we're delivering. And so there are obviously nursing standards that are associated with that. So again, not going to reiterate a lot of this, but you know, the organization has been evaluated and meets minimum standards. The personnel are qualified. The organization is financially accountable. We maintain transparency in our programming and use best practices. And then the individuals receiving services are protected. Our recommendations first is we completely support what the Department of Mental Health submitted during the budget presentation last week, that so the $4.1 million for Medicaid state match. Most of the members that I represent are Medicaid providers, and I can say we desperately need that Medicaid state match. $1 million for detox, and then $1.1 million to enhance prevention services. You know, many of my members did submit RFPs as part of the grant process that the Department of Mental Health oversaw. You know, I'm not standing up here asking for individual amounts of money for the members I represent. They're very comfortable going through an RFP process through the Department of Mental Health or an RFP process, you know, through another entity. But we think it's really important that there is some kind of process that that organizations get to kind of be judged and have proposals and make sure that the funding is not supplanted. I mean, that's a really big deal, is that you know, the members that I represent understand that this funding is for new or enhanced services, not to get money to replace current programming. And then finally, because we
do that.
Wait, what?
You think we would do that?
And then finally, I mean, we just wanted to, we don't know what the process is. And so I wanted to give a list. Like, I talked to all my members and I talked about all the needs. And so we wanted to reserve some type of right if, you know, to either present, if we needed to present individual proposals to the commission or as an association. These are, you know, some of the needs that we just outlined. And they're diverse based on the community and based on the agency. But as you see, there's a lot of need out there. And I just appreciate your consideration today. So,
well, thank you, Holly. This is very important, and I assure you, you will see this language in what this commission delivers as the statewide plan. And certainly, it probably would not be this commission that would evaluate that. It would be through one of our agency experts, and so certainly we'll see that language again. Yeah. Any questions by the members? All right. Senator?
Just thanks for all you do. I know you're all over the state and you're hustling like crazy, and so are your members. And so I appreciate all they do in my hometown and then all the way up to Huntsville with Wellstone. So just thanks so much.
Thank you, Senator Gudger.
Mr. Chairman, I just want to express my gratitude to you for this presentation. I can tell you have a legal background because you've really laid out the codes. What I'm most excited about, that this plan addresses housing, and we are dealing with the advent of homelessness, and I think this is something that we really have to address as a state. So again, I just want to say thank you for incorporating that in your plans.
Thank you. And I mean, housing is a big issue because many times we can't use federal dollars for housing. So we really rely on state dollars to provide a lot of the housing programming. So.
Great work, Harley, to you and all your organizations that you represent. Thank you.
Thank you so much.
Okay, next up, Alta Point Health.
Hello, everyone. Thank y'all for allowing me to be here today. So I'm going to talk about the shortage of psychiatrists in the state and why we need more. I know my friends from UAB, which I did graduate from UAB School of Medicine and did my psychiatry training there many, many years ago. So anyway, I know they've talked about this, but I want to emphasize it even more. So if you've done any reading at all, you know that the number of psychiatrists in the United States is going down per capita, and it's going to reach a critical number in 2024, and further studies show it's going to go even lower in the years past 2024. I'm going to talk a little bit more about this in a minute. So this is our HPSA score, which is our health professional shortage areas, and basically almost all of Alabama is a health professional shortage area for psychiatry. There are some places that are not, but most areas in Alabama are have shortages of psychiatrists. And we know that most psychiatrists are over 55, and we're not going to be working forever. So we've got to get more young people and train more psychiatrists in our state. And while it's low all over the country, as y'all know, everything is worse in Alabama. So while we have a problem in the whole United States, we have a worse problem in Alabama in terms of our numbers. You know, when I was preparing this, I was focused on the shortage, but you know what I realized this morning as I was kind of thinking about what I was going to say, that why does it matter about the shortage of psychiatrists? You know, the reason it matters and why we have to have psychiatrists is, one, Alabama ranks 47 out of 50 states with access to mental health care. And a large part of that is we don't have enough psychiatrists. Another thing is we have only 25% of the mental health force that we need. But why is this bad? If you didn't have much mental health problems, it would not matter. But 1 in 5 adults in Alabama has a mental illness. Everybody in here knows somebody or is related to somebody or has had a mental illness or a substance abuse problem. And you know why this is bad? Not only does the person feel bad and it's overwhelming to the family, but if you have a mental illness, you can't hold a job. You can't take care of your children or your parents. You're going to turn to drugs to feel better. You're going to get addicted to opioids. You're going to use alcohol more than you should. And guess what's bad about all that? Did y'all know that mental illness, if you don't have access to mental health treatment, it leads to increased incarceration? And look at the problems we're having in this state with incarceration. So if we don't have psychiatrists and we aren't treating people's mental health, bad things are going to happen. So we've got to address these things. And you know what's even worse than all that is suicide. There's nothing worse in the world to me than a person dying of suicide because they did not have access to mental health care or did not know that they could get access to mental health care. In Alabama, our suicide rate is increasing. We have 15.8 people die by suicide per 100,000 people in Alabama in the last 2 years. And you know what's even more sad? I'm a child psychiatrist, and what's even more sad to me is in 2021, the Surgeon General, the American Association of Pediatrics, the American Association of Child and Adolescent Psychiatry, and the Children's Hospital Association all declared the U.S. to be in a crisis related to children's mental health. I know y'all know kids in schools that are hurting and kids at your home that are hurting. 1 out of 3 male high school students and 50% of female high school students report persistent feelings of sadness and hopelessness. And since 2021, the teen rate of suicide has increased by 18% in Alabama, and it's not going down. It's the second leading cause of death in kids aged 15 to 24. And we have to stop that, y'all. It's hurting our state. If all any of us even cared about was the economy of our state or the education of our state, all these things are hurting our state in all ways. And we have to stop this. We have to get more psychiatrists and more mental health providers. And I just want to mention that, a big part of what's hurting our children is social media and popular culture out there. The messages out there are just eroding our children's self-worth. They don't feel they're good looking enough. They're not smart enough. They're not rich enough. They're not popular enough. And this really hurts our kids and leads to depression. And that leads to school dropouts, which hurts Alabama for generations to come. It leads to gun violence. There's always something going on in a school with a gun. It leads to school shootings, and it leads to opioid problems, even in teenagers. That problem is present even in teenagers. And as I mentioned, the worst outcome, suicide. But you know what? The good news is these things are all treatable. We can have healthy and happy Alabamians, and it needs to start early with the kids. We need to have psychiatrists available throughout the state to treat our children, because if we don't treat them as kids, which it is so early on when you catch these things. It's like other illnesses. When you catch them early, they're treatable. And then our kids grow up to be happy, healthy, productive adults and good parents. Good parents who aren't using drugs and alcohol and who are able to be wonderful to their children and to the generations of Alabamians. I want to mention a little bit about our psychiatry residency at the University of South Alabama College of Medicine, Alt Point Community Mental Health Center. We do our residency in collaboration with them. And we started in 2006, but in 2009, what we started focusing on was community psychiatrists and the development of an Alabama workforce for rural and underserved communities in Alabama. So our residents rotate through the Community Mental Health Center, and we attract residents. We're not interested in residents who, we're different than UAB. We get residents just as smart, but ours are more passionate about the community and the underserved rather than doing research. In the past 10 years, more than 50% of our residents have graduated and stayed in our local communities in Alabama. And this has been a major positive workflow for Alabama in psychiatry. Our residents are all trained in how to treat addictions. It's a big focus of what we do for our residents because we know psychiatrists are on the forefront. Psychiatrists are often called by our other medical colleagues to talk to us about how to treat patients with addiction problems, and we need to have that knowledge so that we can be there for our other practicing physicians. There, as the dean from UAB mentioned, there's 2 addiction fellowship programs in Alabama. We were the first one, and we've been in business for 3 years with our addictions fellowship, and 100% of our fellows that we have graduated are practicing in Alabama. So we need physicians, psychiatrists specifically, to help solve the opioid crisis. I want to just mention a little bit about our proposal. So our residents work in rural counties as well: Clay, Baldwin, Washington, Talladega. I can't think of them all right now. I had it written down and I skipped that page. Randolph and Coosa. So we're in rural Alabama. Our residents have the opportunity to work with patients in all kinds of rural and underserved settings, which we're very proud of. But we need more residents per year. And somebody was asking about the funding, and I'm not an expert on the funding, but I did want to say this about the funding. The way residencies are funded, they were funded, I'm going to say 30 years ago. And the way the funding came out, you got it for your hospital, and there has been no ability to increase funding. All hospitals that had residents got a certain amount. It's called a cap. And so we got 3 psych residents at the University of South Alabama 30 years ago. Well, that's the cap. You cannot increase the cap in terms of getting any money for it. So our company, AltaPoint, as a community mental health center, has felt it was so necessary to have additional residents that we have add additional residents, but AltaPoint is paying for it rather than the University of South Alabama because there's no money. The cap has not been increased. We can't add more residents. So we are desperately asking y'all to add more residents. Now, I know everybody is asking for money and everybody here has worthy things, but I did want to say that we need more. I just asked for 1 additional psychiatry resident, but you know what? If y'all have extra money, we'll take 3 additional general psychiatry residents. We'd like 2 addiction medicine residents and 3 child and adolescent psychiatry residents because our people are really on the front lines. Just so y'all know, our residents go out with our, at AltaPoint we have a team that goes to see the homeless. We have crisis teams. Our residents go out and rotate with all these teams to see what's really going on in the community in the underserved and rural parts of Alabama. So anyway, I appreciate y'all letting me speak, and I know y'all have a lot of hard decisions to tackle, so thank y'all for your willingness to do that.
Thank you, Dr. Parker. We've certainly been hearing a lot about that, not only from the Department of Mental Health, but also on the DHR side related to our high-risk foster kids and the need for additional psychiatry. Any questions about the Commissioner?
Just want to thank you, Dr. Parker, for your passion and your commitment and what you do every single day. I'm sure it's obvious to everyone in this room how committed you are to serving Alabamians, so thank you for what you do.
I've been doing this for over 30 years at AltaPoint, although I know I don't look like it. Thank y'all.
Thank you, Dr. Parker. Okay, next up, find help.
Thank you, everybody. And I have 3 distinct asks, none of which are for money, so you can give the extra to Dr. Parker, I think. So I am with Find Help. We are a social care referral network. We take care of a lot of people's problems outside and beyond just what happens in substance use disorder. And if you think about it, my family and all of your families all have 100 problems. Until someone shows up in the ER with an opioid overdose. Then you have 1 problem, right? Until you get treatment, and then you have 100 problems again. And so we like to think about it that you've got to really start to wrap around the entire person and help with ways to develop and deal with all of their problems. So we are a Part B public benefit corporation, and what that means is we're mission-based. We have a free to the public website that many of your citizens use to research for help. Some of you may be familiar with it. We work around the country with lots and lots of healthcare. That's where a lot of our business is. But really our job here and our mission is pretty audacious, and I always highlight the word all in our mission statement because our mission is to connect all people with the services and programs that serve them with dignity and ease. And we really take that seriously, and we think whether that's veterans or people returning from corrections, we want to make sure everybody gets treatment. So, this is a quick snapshot of our resources here in the state. These are our customers. We primarily work, as I mentioned, in the healthcare setting. They're really early adopters of the kind of closed-loop referral social care technology that we offer. In addition to that, however, we also have our free site that I mentioned, and of course, we work with lots and lots of nonprofits and community-based organizations around the state, which is why you see the large numbers of users and searches in the state. So our first ask, and I said, and I'm going to keep to my commitment, this is not going to be for money. Our first ask is to help the person, not the addict. And I talked a little bit about the wraparounds that any person who's facing addiction is going to need. And these are a couple of our core principles. One, we don't ever want to define a person by his or her most difficult moment. Having to reach out for housing support, having to reach out, having just returned from overseas for job training because you've been in the military since you were 18, having to reach out for substance use treatment shouldn't define the rest of your life. And then the second principle, and I think this really fits with the culture in Alabama, is that the safety net that we build should be underneath people to help them on their way down, not a snare over top of people to keep them down. So this is a quick look at snapshot of some of our data and searches in the state. You can see utilities is a big one. A lot of states it's actually housing, but utilities is often the case if you don't have as an acute a housing issue. This is recent data. This is all free and available on our website, and we can actually also work, and we've done trainings for legislators and their staff around the country to help them understand how to use our site and how to get this research done. I focus in a little bit on Colbert County because, as well, I'm sure many of you are aware, that is an acutely hit county. It is the highest opioid prescription per 100 people in the state. It is the top 25th highest prescription county in the country. So Colbert County, you can see we get a lot of search activity there. It's very high based on the population. And you can see what those searches are for. And so as you go into Colbert County, one of the interesting things is support groups, which is really kind of an indicator for us on people reaching out for opioid treatment help. That's number 5 on the list, followed by, but there's many more ahead of that and many that come after that. This is another interesting data set that we found in Colbert County. Tuscumbia is not the largest city. Muscle Shoals is the largest city by about 6,000 people. I believe that, if my memory is correct on that. But Tuscumbia has more searches than Muscle Shoals, which tells you a little bit about what's going on in that community. And again, the number of searches in this county per capita is much higher on our platform, which we think is very much related to the opioid crisis. So the second ask, and this is a little bit more specific, again, not for money, we work with what are called claimed sites. So as I mentioned, we work with our customers, Blue Cross Blue Shield, who I know is here. Blue Cross Blue Shield of Alabama is one of our better customers in the state. They're very active and use our platform to help their patients with their needs beyond the healthcare setting. For when we're working with community-based organizations or nonprofits, we're giving them free access to free resources, tools, case management software that they can then use to help people who are being referred by our customers or who are referring themselves through our free platform. This is an example of our platform that is sponsored by Blue Cross Blue Shield. This is what you look at. This is also still in Tuscumbia, and there's 1,812 programs that can help people in Tuscumbia. So you can look up, you put in your zip code, and that will take you to, that's the 35674 is the zip code I plugged in to get those numbers. When I say a claimed program, as you search through our platform, you have what we call program cards, many of which are curated by our staff and are accurate. We check them every 6 months, and if we have a signal that comes in as a problem, for instance, if our data doesn't match their Facebook page, our curators will reach out and call and deal with them. However, what is really the most efficient thing for our customers and for the people we're helping is when we have what's called a claimed program. So a claimed program, this is a claimed program. It's a MAT program that serves Tuscumbia. It's about 8 minutes away from the center of that city. And it is, you can see, it's got a lot more details. It talks about its hours. If you go into the next steps, there's lots of referral information and an intake form that you can fill out. So that's a much more rich experience going into it, and it makes our job easier and our navigators' jobs easier for our customers. So we'll be around the state. In particular, we're interested in making sure that state-funded programs are claimed in our site. So we're meeting with state programs around the country. I can give you some ideas of ones that we work with that are, run by the state. There's a particularly forward-leaning asthma relief in Georgia. So the third ask, and this one is a little bit trickier, but something that you all need to be very thoughtful of. And we all think about data privacy in every setting. And I think whether you are on the right side or the left side of any particular issue, there's a single issue that we can all agree to, and it's that every single one of us has clicked "I agree" one too many times, and not a single one of us know what we've just agreed to. So being sure that with this particularly sensitive data, you're being very intentional about how you handle data privacy and prohibiting the sale of data is very, very important. important. All of the programs that you're dealing with are going to have some version of social care referrals. It's increasingly digitized. We have a very robust privacy policy. We make sure that there's universal consent and that consent is on a per referral basis, and that all of our customers and all of the people we work with sign business agreements that they'll respect that. We also, and this is something that I think is very important, we are investor funded. We don't ever want someone to take over our company and see this data as an asset. This data cannot be sold from us. Other vendors can sell data. Other vendors do use it for risk adjustment. Generally speaking, it's limited in the social care space, but we believe that is going to leak out eventually if it continues. And this is just a quick look at some of the patchwork of how data is protected. We all know about HIPAA. Anyone who's been to the doctor in the last 30 years knows about HIPAA, which is healthcare. So the consumer data around checking into a facility in the state for substance use disorder, that's protected by CFR Part 2. School, anything that goes in through the school counselors, whatever, is protected by FERPA. Social care referrals, unless it is within and stays within a healthcare platform, isn't protected by anything. It's only protected by the companies. It's a new space. So as you all are thinking about anything having to do with a closed loop referral system or anything that's working with digitizing the community-based organizations, thinking about how they handle privacy is very, very important. We're happy to consult, and we've done a lot of thinking on that. So that's a very handsome picture of me. No, I'm just kidding. So that's my contact information. I've got a couple of appendix slides, which if you need me to race through them so you can get to the next presenter, I will, because I usually get the same question, so I have a couple, tricky slides in case. So can I answer any questions?
Thank you, Mr. Chambers. And I may have missed it, so you don't sell the data. How are you currently funded?
So we have customers. Blue Cross Blue Shield is here today. They are one of our very active customers. They pay what's called a software as a service or SaaS business. So if you think about when you have a subscription to Microsoft and opposed to just buying the old discs like you used to, that's a SaaS. That's a software as a subscription, and you pay a monthly fee for that. Our customers pay a regular licensing fee for our software, which gives them access to our referral directories, and then occasionally they'll pay add-on services when we do things like community engagement by building new resources, building new relationships with important. If I had to guess the behavioral health that is in my slide, the MAT treatment, I'm guessing that was a custom build out that we did for Blue Cross Blue Shield, because that usually wouldn't be a claimed site, because I don't think that's a nonprofit.
Got you. Any questions from the members?
I do, Mr. Chairman. Thanks for being here today. It was a good presentation. Just to be clear, you said you couldn't sell your data, correct?
We do not, yes.
Yeah, but you own your data, correct? You or your company directly, or is somebody of your partners that are paying into that, do they own part of that data? Who owns it?
So as far as proprietary, our business agreements and our agreements when you sign into our system all retain the data property with the person who is doing the seeking or the person who's being sought for. So if you are a navigator and you are trying to get Glenn Chambers' social care referral to a food pantry, Glenn Chambers still owns that data. I confirm that I own that data when I get the referral. The people we work with and the food pantry all work with that. Now, the food pantry has access to it, and of course, and the navigators will have access to it as well. But another organization, say a clothing shelter, wouldn't necessarily be able to see that data and we don't own it. The main thing is we can't monetize it. So it belongs based on our business agreements to the seeker.
So the navigator has access, obviously, because they're trying to find out.
Correct.
Obviously, and then the second is your partner, or whoever that, I'm going to say agency that they're going to or trying to find, they have access to it because they're looking for the pantry, for example, correct?
Correct. But they can't sell it or monetize it in any way.
And just to make sure on the navigator, does it cost for the navigator to come in there, did you say?
We have a free, it's called findhelp.org. So all of your staff actually, and we've trained legislative staff before, findhelp.org is a free service that anyone can use. The navigators for our customers will build out, so what you saw earlier was a white label that we built out, so an instance of our site we built that was branded for Blue Cross Blue Shield. Their navigators have a license, and we've trained them on the system, and we do other things. So that's sort of an additive to what's available for free. I will say, if anyone's coming in here and does say you should be spending money on closed loop referral or social care referrals, come talk to us, because they're probably going to charge you too much.
Commissioner, do you have a question?
Yeah, sorry I missed the first part of your presentation, but this is not specifically focused on opioid use disorder or behavioral health.
Correct.
Specifically.
Yeah, we have 1 million use cases, Commissioner. And in Delaware, we work with the Department of Behavioral Health and Substance Use on a substance use disorder program. We also have one in Pueblo, Colorado. We also work with veterans-facing organizations. We work with the DC Ready Center, which is a organization that works on prison release programs. We also work with corrections in Bexar County, Texas. So we've got clients all over the map. As I mentioned, it's primarily our revenue is healthcare focused, but we do everything. So if that referral is for social care or substance use disorder or food pantry or housing assistance, we're there to make sure that we connect them. And we don't do the work; we just make the connection. So.
Any other questions? We appreciate what you do. That's a valuable resource for Alabamians. So thank you.
Appreciate all of you. Thank you very much.
Next up, Partnership for a Drug-Free Community. And as a quick disclaimer, just like I did with the Boys and Girls Club, when I've been a very long-serving board member of this organization, and them, like all the others, I resigned from all my boards when I became budget chair last year. But Cheryl, Russell, welcome.
Thank you so much, and thank you to the Commission for this opportunity to speak to you today. I want to begin by thanking each of you for your hard work and deliberation on behalf of Alabama citizens. This topic is not an easy one, nor is there a quick fix. However, your efforts, I believe, are moving the needle in the right direction, and together I hope and pray that our efforts are really going to create short-term and long-term changes. Today, in addition to hearing from me, you will also be hearing from our board chair, as well as our deputy director for our Resource Recovery Hub, and also Partnership for a Drug-Free Community. As the executive director, I wanted to share with you that we are not the largest organization that you will see before you. In fact, going into 2024, there were 8 employees. And we've all decided that individuals who work for nonprofits are unique individuals who really care about our mission. We were founded in 1988 by a woman who had lost her only son, her only child, to a drunk driver. And she committed right then that she would lead Partnership, and she did so until she passed away in 2017. So from 1988 to 2017, Deborah Soul. And her last name is so fitting because her soul and her mission was to provide education, awareness, and prevention around drug, alcohol abuse. And for the past 35 years, that's exactly what Partnership has been doing. We have been located since the beginning in communities where our services are so needed. We actually have 2 arms at Partnership for a Drug-Free Community. One arm is education, awareness, and prevention. Our funding comes from private donors, from fundraisers. You will see in the packet, we have a fire truck pull, and members of the community come out, and there's team building, and that's a large fundraiser for us. Corporate donors, individual donors. We have a grant that we have had with the Alabama Department of Public Health going into its 3rd year on tobacco, nicotine, and vaping. We go into the classrooms and provide for students, grades 2 through 12. We have another program called Aussie Ops, opioid prevention, and we go into classrooms that was written by one of our AmeriCorps Vista employees, who is now an employee doing primarily education training for new individuals that are coming in to deliver those programs in the classroom. We partner with schools in Madison City, Huntsville City, and Madison County, as well as parochial schools and after-school programs to deliver that opioid awareness training to children at an early age. And we see this as a driving force for the long-term change in this state. And while we have not asked for funding for Aussie Ops, Aussie is an ostrich, just so that you know. And it's fun, and the children love Aussie, and we really see an opportunity to expand that program, not only in Madison County, because we've done it for several years and it's been successful, and our focus is on using what we have done and what we have done well to expand to help our neighboring counties. When partnership was formed in 1988, when you look at the top half of the map, or the top 25% of the map, there are 10 counties. We recently proposed to the Opioid Settlement Commission expanding and doing a regional support expansion into Marshall, Morgan, Limestone, and Jackson County to take what we've already done and go into those counties and share that success. Because initially, the goal was to expand into the top 10 counties in North Alabama. What is unique about Partnership for a Drug-Free Community? We don't provide treatment. We don't provide recovery services, but what we do is, and what we have done, when the hub started 3 years ago, we realized that there was a need to connect the individual who finally decides that they want treatment. And so since the very beginning, our niche service has been to provide the state-approved American Society of Addiction Medicine and Substance Abuse Placement Assessment to that individual who has decided, I want treatment. Because we have realized when that individual decides they want treatment, we need to get that appointment for the assessment, we need to do the assessment, and we need to connect that individual to treatment just as soon as possible before they change their mind. Another thing about partnership is that we really believe that we reach a population that is falling through the cracks. Unhoused veterans, unhoused individuals in Huntsville that live on Seminole Street. We don't have slides for you to look at, because when we go into the community and do Days of Hope, we go to those Seminole streets and we do education outreaches and we talk to the individuals who really need services and really need to know that hope is real. When individuals come through our doors, they really become family. That's not something that we take lightly. More often than not, they may leave with a prayer being said with them and a hug, because when is the last time that, somebody has put their arms around someone that's unhoused? And what's really interesting is that I'm usually the first one to release the hug. They just want to keep on hugging and hugging because it's probably been so long since they've had one. But we take what we do serious. We advocate for that individual and we represent that individual. We're not tied to any facilities. We advocate and we find out what is best for them. Do they have insurance or not? Would they rather go to a faith-based treatment facility or not? And then we do the assessment and we make referrals. We have partners all over the state. You saw where all of the treatment facilities were earlier. And we have collaborative agreements with all of them, and we refer to all of them. Since the hub was founded it was conceived in 2019, we opened our doors in 2020, right before COVID. We're a small organization, but what do you think happened in 2020 when individuals couldn't go somewhere in person? We were nimble, and we started doing virtual assessments. And we've perfected that, and we're able to continue to do that, to reach into very remote areas in North Alabama. We have handled over 1,000 inquiries for treatment services in the past 3 years, with over 300 individuals having had the ASAM assessment, and we've connected them to varying level of treatment services and organization and facilities across Alabama. We are all about connecting that individual to treatment. From the time an individual decides to seek help, again, we try to shorten that window. An example is we always hear the bad stories, and I liked what you said about not labeling that individual. One Thursday night, a young woman came into our office at 4 o'clock. She was from Florence, not even in Madison County. She had just lost her child to DHR. The child's father had died of an overdose. Unfortunately, she found herself in a situation where a weekend of bad choices, by Monday, she was in withdrawal, and that's when she lost her child. And she found us by our post office address. Now that is, to me, a sign of wanting and knowing that she needs treatment. She came in her own automobile with $400 in her pocket. That in and of itself is not a good thing. Well, by 1 o'clock the next day, we had her on her way to a treatment facility. She wanted it, we were there, we met the need, and it happened just as fast as we were able to help her. We have further addressed our need and desire to help the opioid issue by providing ongoing fentanyl and overdose crisis intervention, and we've been providing education on the use of fentanyl test strips, as well as the use of the identification of xylazine, trying to let individuals know that they can walk into our door, have a small intake process, and then get the strips. In your binders, there is a report on partnership by the numbers, and even though we are a small organization, we have provided direct services to over 5,700 individuals just this past year. We are ready to expand our services into not only Marshall, Morgan, Limestone, and Jackson County, but also into Lauderdale, Colbert, Franklin, Lawrence, and DeKalb. With adequate staffing, we want to do that, we're able to do that. The expansion of our Aussie Ops program, I believe that once you listen to Mr. Battle's presentation, you will realize that we have not only the capability and the staffing, but also the desire to work with jail-based and post-incarceration programs. And so with that, I'm going to turn my time, if I have any left, over to Karen Krausen, our board chair. Thank you.
I'll be very brief. My name is Karen Krausen. I'm chair of the board for Partnership for a Drug-Free Community. My background is I'm a retired, excuse me, I'm a retired hospital pharmacist. I understand what we're doing. Not only am I chair of the board, but I'm also part of the Partnership Speakers Bureau. I do town halls and forums on the panels of when we hold those with other speakers from police department, EMS, the coroner, law enforcement. As Cheryl mentioned, when we started this in 1988, and for 35 years, we've been the leader of drug prevention education and awareness throughout Huntsville, Madison City, and Madison County. It was during these drug forums that we kept hearing parents talk about the struggles they face trying to help their young adult children deal with substance abuse, and many of the parents talked about their children overdosing and dying. These stories broke our heart. Overdose deaths in Huntsville were steadily increasing. In 2019, Alabama ranked 19th in the nation for overdose deaths. So we at Partnership knew we had to make it easier for people with substance abuse issues to find the help they needed. We spent several months working with an advisory board that included a coalition of participants in the recovery and assessment space, and stood up the Recovery Resource Hub in February of 2020. As Cheryl mentioned, it provides a one-stop shop where people with substance abuse issues can talk to a state-certified peer recovery support specialist, receive an assessment to determine the level of care needed, during that, they're taught about alcohol and drug education during the assessment to help increase the individual's awareness of the negative effects their specific substances have on their bodies. The clients, after this assessment, the clients are allowed to decide what treatment options are best for them rather than being prescribed a generic one-size-fits-all. This is best practice because if the individual is invested in choosing the treatment, they're much more likely to follow through. Partnership has removed cost as a barrier to access care due to the individual's lack of financial resources. The assessment is provided free of charge. A large number of individuals served by the Hub's program have been our unhoused and underserved population. Along with assisting people into treatment, the Hub is also an information resource for families and friends trying to handle the stresses that come along with having a loved one who is in addiction. A September 2022 report by the Joint Economic Committee stated that the economic toll of the opioid crisis reached nearly $1.5 trillion in 2020. A 2021 review of the high price of the opioid crisis reported by the Pew Charitable Trust stated that each dollar invested in additional treatment reduces drug-related crime, theft, and criminal justice costs by between $4 and $7. Expanding the Hub into these surrounding counties will increase access to treatment services for individuals in our rural and less urbanized areas. Partnership also has the capabilities of providing virtual assessment services. Thank you.
Good afternoon, Commissioner.
David, good to see you. Yes,
hey,
sir.
Good to see you. And everybody else in my cohort out here. It's important for me that I'm here. And I want to take you back to 1988. 1988, when Partnership was founded, I had signed a scholarship with Auburn University. Number 47 recruiting the nation. Honorable mention All-American. I would go on to get 2 SEC rings, to play on the first team that played the Iron Bowl down at Jordan Hare. And you would say, great times. But in the midst of that, I was dealing with my father, who had come from Vietnam. I was born in '69, and he was in the midst of his own war to get benefits, to get accepted. He would go to prison 3 times because of addiction, because of his mental illness, because of schizophrenia, because of PTSD, because of things that I didn't know at the time, because I was a child and grown folks said, this is grown folks stuff. Son, y'all stay up there. The only thing I heard was money was the problem. So I thought that would be the answer. I gotta do what I gotta do. I'm gonna go to the NFL. I'm gonna make everything all right for my family if I make this money. I would go on to tear my knee up. Spring practice of my freshman year at Auburn. Then I would get caught up in a war of my own. And that was that war on drugs that was going on. Went to prison twice. 1990, entered treatment in prison. Would go on to Limestone Correctional Facility. Would start working with a counselor that cared, Miss Gloria Ward, who was in the special unit there. That was when they segregated anybody that was HIV positive. I would walk her over from population, stick with her the whole way, and learn the trade of counseling from her. But more than that, I would learn how to care about people at their lowest point there. I went on to model my life and my style of counseling after her. And I committed to helping people who were trying to get through this addiction, but first I had to get my own healing. In the midst of that, I was released. I went on to get 5 degrees. Went to Calhoun first, and then Athens State. Then I went back to Auburn and finished up. Then I went to Alabama A&M University and got my master's in counseling and psychology. But along the way, I went through Wellstone, which was the Madison County Mental Health Center back then. Graduated the program, stayed in the aftercare, finished the aftercare program, and they offered me a job. And I had just gotten settled in. I'm going to school full-time at Calhoun. I'm on the back of the garbage truck. And they offered me a job in the field as a prevention specialist. I had to talk to my wife because what they also offered me was a pay cut. They'll pay you more to pick up the trash off the curb than to help people pick up the pieces of their lives. She said, baby, you gotta at least try to negotiate something. So I didn't take a $2,000 pay cut, it was a $1,000 pay cut. $17,000 a year, I just got up to that. Dropped back down to 16, I said, I'm here where I need to be. Continued on and started making my mark in prevention under a grant that came from the Department of Mental Health. And my kids, my 3 boys, were in every class that I taught. They would go on to become counselors. 2 of them at Limestone Correctional Facility, mental health counselors. One is a counselor, career counselor in Texas. The number said, and this was what I remember when I was in prison, 84% of the male children of an incarcerated male will also be incarcerated. My father had 3 boys. I went to prison, brother went to prison, my baby brother went to jail, and that statistic rang true. My 3 boys, 2 of them went to Tuskegee, 1 went to Auburn, in their own, raising their own families, and they're all counselors and helping people. I had to make a difference in my life. I had to make the change. I made a commitment to help other people through this piece. I would go on to go back into Limestone as a drug treatment counselor. Was there for 5 years as a counselor when Mama Ward retired. I had the opportunity to sit on the advisory board for Governor Riley on recovery and reentry and to input some stuff from somebody that had been there, to share an experience of somebody that had been on the chain gangs that were reinstituted, to share a life of being an overcomer of the circumstances, of the pains, of the hardships that I had caused on my family from addiction. Partnership has played a very important role in my life because in 1998, it was formed. When I started working at the Mental Health Center in 2001, the soul of Partnership, Deborah Soul, gave me my first speaking opportunity at the Huntsville Country Club. And in that audience sat the sergeant that sat with me, who had become the sheriff of Madison County, who was on the board of Partnership, Blake Dornan, who was recently passed. Sheriff Dornan as a sergeant back in 1992, sat with me in the hospital when I almost died and had to get a trach in the county jail. And he talked to me about being a man and about being Christian. He talked to me as a man. I'll never forget it. And I made sure to contact him and stayed in contact with him when I got out. And I had a chance in that first speaking engagement to thank him face to face. In that audience also that day, back in 2000, was Rob Broussard, our current DA in Madison County, who prosecuted me, my dad, and my brother as an assistant DA. I had a chance to thank him for seeing something bigger in me and giving me opportunity. And I stayed in touch with them, and I still continue to stay in touch as I take the message of prevention, of recovery. I've been in this field for 20, grief, it's over 20 years. I started back in 2000 with an opportunity right here at Partnership. I went on to go to Limestone, then at Wellstone, and then at Thrive, Alabama as a project coordinator for 12 years. And last year I came back to Partnership. I stepped away as a board member for Partnership in 2017 because when Ms. Deborah died, my brother had also passed that same year, 2017, in a drug-infused, alcohol-infused car wreck. But I had an opportunity to come back, be on this field to make a difference. Now, I'm an old defensive lineman. I keep my hand in the dirt. So wherever the people are that are hurting, I'm gonna be there to fight for them, to fight with them, to walk with them through the process. That's the blessing of Partnership. I've had a chance to be there as people are hurting and understand it's no judgment. And explain to them it's no cost. And that I don't have a commitment to any agency in this state to send their referral. Wherever you want to go, whatever you need to do, whatever you feel is best, we can do that. And I get a chance to do that with Carl Wilkerson, our clinical services director, who watched this God thing right here. And I'm going to sit down. Carl and I started to work at the mental health center back in 2001. He was coming out of grad school. And I explained to him, and he reminded me of this, because he was fresh out of grad school, didn't know about addiction. He said, you remember when you told me sometimes you got to use a scalpel, you can't always use a hatchet. So me and my partner are the scalpel and the hatchet over there, partnership. We get a chance to make a difference. We've reached a lot of people. And we're going to continue to do so. I've never asked for money because I may do it what I have. But an opportunity to be funded and to bring some other people into this thing, to reach into other counties, will be golden. Thank you for this opportunity. Thank you for seeing a chance to make a difference. Thank you for letting me be a part of the resolution in an epidemic after coming through my war.
Co-chair.
David and Karen, thank you so much. And I get to work with these people every single day. Do you have any questions for us? We'd be more than happy to.
Questions from the commissioners?
I've got some for the gentleman that just spoke, if that's all right, Mr. Chairman. Is that okay?
Absolutely.
Is it Mr. Battles?
Yeah.
Mr. Battles, this is a crazy question, but I'm asking just right here instead of the whole room. But first of all, there's a reason I'm asking. Are you a preacher?
I'm not. I am not.
The reason I ask that, because I'm telling you, you just kind of brought the Holy Spirit up in here, just number one. Number two, you've got an anointing on your life with your story. You gave us all inspiration in this whole room. We've listened to a lot of stories over the last few months. Yours is amazing. And I just smiled back here listening to you because as an old football player, but at the same time, seeing how you've overcome, and then you're back out there and you're saying, I'm going to do with whatever I've got with that $16,000 or $1 million. I appreciate your humility and the way that you're going to work, but you have an anointing on you, and you need to keep telling your story, your life story, and everything that's happened to you to these young men all over the state of Alabama, because there's so many of them that do not have men in their families anymore, and you can give guidance and leadership and inspiration and peace to those guys that are struggling, anywhere from young men all the way to our age. So I just want to tell you, I really enjoyed your time, and I know I'm kind of off, but I'm not saying any of this for anybody in this room except for you and me looking at each other. So just wanted you to know that just from me, okay? Thank you.
Yes, sir. Thank you.
David's come a long ways since I first met you on the enforcement side, unfortunately. Thanks, sir.
Yes, sir. Me and my dad.
And your dad, yes, sir. I'm not that old, am I?
Thank you so much.
Next up is Thriveway.
Good afternoon. Thank you so much for the opportunity to be here. My name is Allison Moore. I'm the co-founder and president of Thriveway, and I am honored to be able to share with you about the Peer Helpers Plus program. Our methodology is one of impact. It starts with educating all students K through 12 in public schools on PATH, and that represents prevention and awareness for total health. Our goal is to make sure we provide equitable services to all students at all 13 grade levels to meet the state mandates and help them build coping skills and resiliency to battle the life that we're in today. Layering that with a peer-to-peer support group, not only do we have prevention, but we have early interventionists. Research shows that if a student is dealing with something, they turn to another student first, and then they turn to an educator, and then a parent is usually about fifth on the list by the time the student gets home. And if we have those two components in place with accessible curriculum and a data component piece called our portal, along with a coach who is a retired but not tired educator who wants to still get back, be involved, and be there to support our schools, we can make a difference through a layered, multi-tiered system of support. Our entire goal and purpose is to reduce the number of risk for referrals. High risk and at-risk students are going to be there, but if we can reduce that quantity by early intervention, addressing something when a student is going through something that is a fire or a flame before they are on fire and running in a crisis mode. We know the power of early interventionists. We've heard from so many people that we don't have enough, suppliers with that referrals. We don't have enough mental health suppliers, mental health professionals. We do know that with all mental illnesses, about 50% are diagnosable by the age of 14. I was a freshman in high school when I was 14. By 14, we could have early intervention to really intercede with students who are showing those signs and symptoms of struggling, and that's where we focus our efforts. There are many laws that are required for education to meet, and 4 of those are on the screen in front of you. Those are our prevention mandates. When these were rolled out at different times in different years, they were unfunded mandates. Now, through the Education Trust Fund, there is a line item called Bullying Prevention Project, and that is where the majority of our schools that we work with get funded. And the reason we work in this methodology to work with all of these prevention mandates is because we know at the heart that suicide is the second leading cause of death for anyone the age of 10 to 24. I know it was said earlier, but it is the root of why we do what we do. But we also know that working on suicide, we have to associate all the warning signs, the risk factors, and that is those other prevention topics. So we have the Jamari Terrell Williams Act, which used to be the Bullying and Harassment Act, which is now bullying and cyberbullying, because as our world evolves, our students are needing more support, not just with interactions, but with internet interactions and those digital networks. We have our drug education abuse, which is a huge highlight of why we are here with our opioids. And then we have the abuse, not just abuse of physical or emotional, but also sexual abuse. And when a student is going through something such as sexual abuse, they may turn to less self-value or self-worth. They may turn to the medicine cabinet and find the Lortabs left over from someone's surgery, or dealing with something that they're trying to self-medicate and build their worth and value up. We address all of these in a comprehensive manner, but in your folders, you're going to see in your binders how we address opioids. So we provided you with an entire sample of what we provide to our schools in regards to our PATH component, that full K through 12 educational component, that curriculum, where you can see what is said to our students, how we are addressing opioids, one little snippet and sample of that, but that opioids is an ongoing issue. A few years ago, we weren't just talking about cigarettes, we were talking about vapes. Then we were talking about the fact that there's THC in vapes. Now we're talking about synthetic heroin in vapes, and things can be laced with fentanyl. So our students are needing that up and coming and trending current issues that they're faced, and that's why we are making our curriculum accessible through our online portal. Our means of communication is to ensure that we are relatable, we are current, and we are meeting the needs for education in the prevention sector. Also, not only layering it with the all-student faculty-driven component, we have our student peer-to-peer support, and I call that the magic relationships. We all know that every youth needs at least one adult that they can turn to and relate to, but our students, when they need something, they're leaning to each other first. They're sharing with each other. They're getting guidance and support. So when we learn of a student who is turning around and creating a concoction with purple Kool-Aid and using NyQuil and other things from the medicine cabinet to start mixing, including our opioids, we want to make sure our students' voice echoes that of the adults from the PATH component, that they are sharing positive information. So we also have in your binders an entire campaign on drugs and alcohol that's provided to our middle and high school students. To stay current, not only do we want to make sure our information is correct, but we want to make sure that we're current to their ear. So we suggest morning announcements to music and songs, to things that kind of create a positive energy around a hard to talk about topic. I remember when it used to be, this is your brain, crack, sizzle. This is your brain on drugs, just say no. For some of our students, it's hard because they're getting picked up by someone who may be under the influence, even getting a ride to school in the mornings. Having ways to not only tell them what's out there that could harm them, but ways that they can protect themselves. Teaching them and having them practice ways on, I'm sorry, I can't do that because, I mean, if coach finds out, I won't get to play on Friday. And if I don't get to play on Friday, somebody won't see me. And if no one sees me, where will my future end? I want to have hope in the world. Teaching them, but having them practice it, because sometimes we know something, but until we've actually done it, it's not into our memory of an instant reflex and response. So that is why we have our peer-led, student-led campaigns on schools. Right now, you'll see we are working with 101 public school districts from city and county, and then a mixture in some areas. We have been growing and are looking at about 20 more districts has been our average each year. So we are really close to having a statewide opportunity to provide equity, not only for all of our 13 grade levels, but for every student. I currently live in Baldwin County, but I'm from Clark County, Alabama, and I will tell you, not every community has a local mental health resource. Not every community has a substance use or a drug educational counsel that can come and speak to schools. Having resources and things right around your fingertips, especially as we get more rural, is so important for our students. They need somewhere that they can turn to provide information not only for the educator and the student, but also the parent. You'll notice when you look through our curriculum that we have parent resources, letters, information, hotlines to give them tools, because so many times we hear a parent say, I just don't know where to go. I don't know where to turn. I don't know of anything in my community. And we go, just because it's not in your neighborhood does not mean there's not resources available. Our partnerships and collaborations between Children's of Alabama and working with our mental health facilities and Alta Point that you've already heard from, as well as all across the state with our education department to serve, to be able to provide a resource to not only address opioids, but the things that may cause students to turn to opioids as a solution is a huge part of why we do what we do. I will say everything in what we do is personal. Being a mom with a child, being a mom with a child who used to be married to the bipolar addict, the person who would go in the medicine cabinet and wipe it clean. I have seen firsthand not only what it will do to an adult, but I can tell you what it looks like for a child. A child at the age of 3, the child that when you pick up from pre-K has the marijuana pipe in their book bag, the child that is having to juggle the different atmospheres and environments that opioids and other drugs do to them or to the person they thought was supposed to be their protector and their haven. I thank you for taking this stance and making opioids an important issue, because it is real, it is everywhere, and for some of our students, they don't even realize what they have, but they have it at their fingertips. So our ask is to help us make it statewide, get into these other 50 districts as we are working to provide for all of our students.
Thank you, Allison. Any questions by the members? All right, thank you very much. Appreciate what you do. Next up is Alabama Association of Addiction Medicine.
All right, well, thank you. Is our slideshow? There we go. Okay. All right. Well, thank you for having me. I'm Luke Angerizer. I'm the president of the Alabama Society of Addiction Medicine. We're the Alabama chapter of the American Society of Addiction Medicine. And we are the professional society for addiction medicine physician specialists in Alabama. So throughout the state, physicians generally in Alabama are represented by the Medical Association of the State of Alabama, MASA, and then individual medical specialties will have their own professional societies. So we're the professional society for addiction medicine physicians in the state. Our primary mission is to educate Alabama physicians on assessing and treating substance use disorders, and also advocating for evidence-based addiction treatment in Alabama. And what we mean by evidence-based is we believe that appropriate treatment should be based in data, research, and science, and we try to provide the best state-of-the-art treatments that have been shown to be effective. Now, I'm going to go back a little bit and talk about the opioid epidemic, and tragically, we have to be honest, physicians largely got us into this mess. Physicians throughout the U.S. and in Alabama overprescribed opioids to an absurd degree in the 1990s and early 2000s. Now, we were led there by other helpers. So one big one was accrediting bodies like JACO, Joint Commission, Medicare Administration. They came up with this concept in the late 1990s of the fifth vital sign. Pain is the fifth vital sign. So we check blood pressure, we check pulse, we also ask about pain with the little smiley face scale. And if there was any number above 0, that needed to be addressed. So we had this requirement that as physicians at every visit, we assess for pain and we treat pain. We got some help from the pharmaceutical reps that said, hey, we have a solution for your problem. OxyContin. This will help the problem. So we had a concerted misinformation campaign by pharmaceutical companies to physicians telling us that it was not only okay to prescribe opioids, it was safe and appropriate. That's what we should be doing. I know Dr. Boyette went through that in a lot of detail last session, so I won't go into that again, but I just want to emphasize that physicians were on the other side of a multi-million-dollar campaign to spread misinformation about the relative risks of opioids, and that's what we're fighting against. So just like physicians helped get us into this problem, I think physicians play a critical role in helping get us out of this problem. Now, we have life-saving treatments for opioid use disorder. We have medications like methadone, buprenorphine, naltrexone, naloxone that have been shown definitively to save lives. Absolutely no question that they are life-saving medications. But tragically, we have a severe problem with undertreatment in this country and in the state. So only 18%, less than 1 in 5 individuals with opioid use disorder are receiving these first-line life-saving treatments. This is partly because of a workforce gap. We have very few addiction medicine physicians in Alabama. We have very few psychiatrists, as Dr. Parker mentioned earlier. But the other big problem is just a lack of education among physicians generally on how to use these treatments. So a couple of years ago, the federal government removed a lot of the restrictions on prescribing buprenorphine, and the hope was that that would greatly increase the number of physicians that would prescribe buprenorphine for people with opioid use disorder. But tragically, it's barely moved the needle. It's barely made a difference in Alabama. And I think the clear reason why it hasn't moved the needle is that physicians generally just aren't comfortable prescribing it. They don't know what to do. They don't know how to use the medications. And we have a big gap. We don't have enough addiction medicine physicians and psychiatrists to treat everybody in the state that needs help with opioid use disorder. And we have to get physicians generally much more comfortable with using these life-saving treatments. So we're fighting against misinformation by the pharmaceutical companies. We're also fighting against the fact that medical schools have done a terrible job about teaching about substance use disorder. So more than 20 years ago, there was hardly any education on substance use disorder. So any physician my age or older probably got almost nothing in terms of education in medical school. That's changed. Now, most medical schools do provide education, but that may only be a few hours out of 4 years of medical education in specifically about substance use disorders. And after graduating medical school, you go to a residency program for additional training. Residency programs generally, outside of psychiatry, provide very little education on treating substance use disorders. Had an interesting story. I had a physician, family medicine physician, reach out to me because she was kind of tasked in her program with starting a buprenorphine program with her resident clinic, and she didn't know how to prescribe buprenorphine. She had never done it and really needed help with understanding what would go into setting up this clinic and providing appropriate treatment. right. So again, not enough medical education, and then we're fighting against that misinformation campaign. So what we're proposing from the Alabama Society of Addiction Medicine is to really provide a lot more education to physicians throughout the state generally and teach them how to prescribe these medications appropriately and get a lot more first-line appropriate scientific treatment out to our community. So we are very committed as an organization. We have met and really see this as our primary mission of the next few years, is to try to reverse this tremendous problem that physicians were so integral in causing, and helping physicians to be empowered to really lead the way in helping people with frontline treatments. So we do have some challenges. We're a very new organization. We're less than 10 years old. There are not many addiction medicine specialists in Alabama, so we're a relatively small organization. Like a lot of people, we had a lot of trouble during COVID. We almost kind of disappeared as an organization. We had to donate some money from some of our physicians to even keep going. Right now, we're holding one scientific meeting per year using borrowed space from a hospital, and we can do so much more in terms of educating our physician workforce in the state. So what we're requesting is an allocation to help us in that mission. So we want to expand our annual meeting. We want to provide additional education to physicians throughout the state, specifically on how to use things like buprenorphine and naltrexone, how to do an appropriate substance use assessment, how to help people get started on these medications. We especially want to reach out to medical students, residents, and early career physicians, because they are our future. We want all of them to have a strong foundation in treating substance use disorders. And we also know that we can reach a lot more physicians throughout the state with more online visibility. So we are looking at having online educational programs available that physicians can access and get free continuing medical education hours. All right. So thank you for your time. Are there any questions?
Thank you, Doctor. Any questions for? Thank you very much, sir. Okay, appreciate the information. Next up is new season.
Hey, good afternoon. Okay, there we go. Hi, my name is Mary Beth Puckett. I am the Grants Director for New Season Treatment Centers. I am a lifelong citizen of Pickens County, specifically Carrollton. So this is a whole full circle moment for me to be here with you today, advocating for something that I am very passionate about. So a little about New Season. We are in over 20 states, and we serve over 31,000 patients daily. We are over 35 years old, and we are a nationwide group of accredited opioid addiction treatment facilities. We have a commitment to the highest level of quality service, continuous improvement, and using the most innovative recovery techniques. Our mission is to triumph over opioid addiction by integrating treatment, counseling, and compassionate patient care that saves lives. And our vision statement is the trusted national leader in opioid addiction and recovery services, providing each patient an unmatched personalized patient care experience based on the most advanced treatment methods. Our goal is to deliver the highest quality of patient care. We provide counseling to support the changing of the behaviors that is needed during treatment. We build individual resilience as part of a relapse recovery strategy. We teach ways to help patients restore and improve their daily functioning and life skills. And we support patients to reintegrate into their communities, families, and support systems. So a little information regarding medication-assisted treatment. Within a 3-year treatment time, we see employment rates improve to 83.1%. We see crime rates reduce in 3 years, down to 2.2%. And we see a reduction in illicit non-prescribed use down to 13%. And that all happens from the first day of treatment within 3 years of treatment. This is our staff that we have at every one of our treatment facilities. We include a program director that oversees all operations. We also have a pharmacist on staff that oversees all distribution of our medications. We have a medical director that oversees all prescribing. We have a counseling team, so you're not just getting medication, you're getting a full treatment. You're able to talk to someone about what's going on, what are the triggers I'm having. And then you also have your nursing team that assesses every day your symptoms, your withdrawal symptoms. Are you getting better? Is your medication holding longer? And then we also work with our communities. We raise awareness through community outreach. We participate in local community events. We partner with medical communities. We volunteer with Specialty Task Force, as I'm here today presenting with you. We coordinate with local drug courts and prisons. And we also work with law enforcement and fire departments, whether it be Narcan training, whether it be maybe they roll up on a wreck and they find a medication box and they don't know what to do with that. We train them how to, contact us, let them know what that medication is and how to take it in if for some reason that patient is taken to the hospital. All of our treatment facilities are heavily, we are licensed, registered, and approved by SAMHSA, the DEA, State Board of Pharmacy, the State Opioid Treatment Authority, and CARF. So now that I've talked a little bit about our national work that we do, I want to narrow it down to what do we do in Alabama. In Alabama, there was over 143 substance use treatment facilities and over 19,000 patients in substance use treatment as of March 2022. The overdose deaths, as we've heard many people speak about today, 70% of those were opioid related. And then emergency room drug-related visits, 33% of those were opioid related as well. So for new season, we have 5 treatment centers located here in the state. We have 2 in Birmingham, 1 in Montgomery, and 1 in Mobile, and 1 in Huntsville. So a lot of times we talk about the funding sources, how do patients afford treatment? So we do offer insurance with Aetna, Beacon, Cigna, Humana, the Veterans Affairs, and United Healthcare, and that list grows every day. We're expanding to try to make sure that we can offer access to treatment and financials not be a barrier for anyone. So what we did on a national level as well as an Alabama level is I did a survey to say, what are the top 3 things that your patients say are a barrier to getting the treatment that they need? And I'm also, just for reference, I also ran treatment facilities as well, so I knew that, what these answers were going to be. And in no particular order, we always receive transportation, staffing, and finances. Luckily, here in the state of Alabama, we partner with the Department of Mental Health with the SOAR grant, so luckily finances has dropped to the bottom for us, along with our insurance. Although we still do have some patients who struggle with finances that just fall through the cracks. But the top 2 were going to be transportation and staffing. Only one of our clinics has a bus stop, and the rest are just kind of figure it out. Whether you hop a ride with somebody or maybe you have to miss your dose for a few days, which then can lead to a risk of relapse. So ways to increase access to care, talking about transportation. We are joining forces with Uber Health to create a partnership to allow that access for patients to be able to get transportation to come to treatment. So what I did was I listed our treatments, our treatment facilities here in Alabama, and how many patients we kind of guesstimated, looking at our patients and polling them, how many would need transportation services in order to get their treatment daily as prescribed by the doctor. So these are the figures that we were able to come up with based on the estimates from Uber as well. We work with Uber in 2 other states that we are piloting this program, so Alabama will be one of our biggest states to pilot this if we are approved. And then our second concern that patients and staff also relayed to us was the increase to care through increasing and improving our staffing. As many people have presented here today, there is such a lack of psychiatrists, nurses, pharmacists. There's such a lack of people that are so necessary to running a treatment facility. If you don't have nurses you can't open, then someone has to go without their dose. Then you're at risk for people relapsing. If you don't have a doctor, you can't do intakes. People who finally hit that day where they said, I'm ready, today's the day I want to get treatment. Sorry, we can't take you because there's not a doctor here to see you. You know, these are things that really wear on the ability for people to access care. So for our requests, these are the 2 requests that we're making for our 5 clinics here in Alabama. The $895,000 toward the Uber Health platform, and then we are looking at $536,000 for staffing needs, which would include training, recruitment, like someone said, you know, accessing more CEUs for staff and having staff that are really, that want to be there, want to be involved with the patients. So that is a brief summary. So I know everyone has a copy of the slideshow, but I'm open to questions.
Thank you, Ms. Puckett. Any questions from members?
So is your organization a for-profit or a nonprofit organization?
We're a for-profit.
Okay.
Yes, ma'am.
And just looking at the transportation cost, it seems pretty expensive per person. Mm-hmm. And I want to make sure I'm understanding that for 5 patients, it would cost $71,000.
So that is based off of Uber Health's estimate. They basically just did an estimate of, you know, it would be $40 round trip per patient per day. So for instance, for the first 90 days, when somebody is in induction, they're going to have to come every 90 days. And then after that, if they're doing well, then they can earn take homes and it would be less. So then that money would go further. So this is just based off of if a patient had to come every day for a year, that's what that number is.
Go
ahead.
Just a quick comment. We have actually experience with Uber Health. The Veterans Health Administration uses Uber now to transport patients to VA facilities. So if you're looking for a track record, might be a good model to look at.
Okay, great. We're starting actually this week in another state, so we're hoping for really good things. They've been real great to work with so far.
Senator Grudger.
I want to follow up on that same thing, the transportation costs. Representative Rafferty's not here, but he said has the same questions. Is there special negotiated rates through Uber? How does that work? Or is that something where they supplement, you know, we just pay and supplement that at the VA? Or have you continue to talk to Uber at all about something like that to get people to and fro? But I'd love to, what they're doing at the VA is great, just to know.
Yeah, it's called Uber Health Connect. They sign a contract with Uber, and the transportation coordinator at each Veterans Health Administration facility arranges the individual transportation.
Okay. And that's essentially, from what I understand, that's how this would work as well.
Yeah, and they use many transportation programs, including like Disabled American Veterans has transportation vans, but it's just one tool that they use.
Okay, great.
Thank you, Ms. Puckett.
Yeah, thank you.
Our final presentation will be maximizing mental health.
May I say something, Chairman, real quick?
Absolutely.
Senator Andrew Jones had called and made sure that we were paying attention as the last one comes up, but I think he's your senator and wanted to make sure that he knew that he couldn't be here because he's in another meeting, but wanted to put in a good word for you already. So thank you for being here.
Thank you very much. My name is Kelly Cochran. I'm here today with my husband, David Cochran. We would just like to say thank you from the bottom of our hearts for allowing us to be included today. And I wanted to direct your attention to the young man standing between the two of us. That's our son, Max Cochran, and he is the reason that we are here today. We began an organization, a 501c3 nonprofit that was named after our son, Maximizing Mental Health. Max was a beautiful, brilliant, witty, I could just go on and on, but I know I can't because time won't allow, but he was our life, along with our daughter. Max faced mental health illness from a very early age, and he had many, many struggles. And in the end, his struggles became so great that he was not able to overcome. He could not endure those struggles any longer. I read this somewhere not long ago, and it says, you cannot begin to understand what you have not experienced. I'm going to say that again. You cannot understand what you have not experienced. Our family has lived through mental illness. We know what it feels like to watch someone that you love so much struggle just to face life every day. So we knew early on, I'm sad that we're here today, but I'm also grateful to be here because we have a responsibility to be here. Our son, we want to keep our son Max's memory alive. We have such pain, but we can't do nothing. We decided early on that our son would be so disappointed if we didn't try to help someone else and turn this pain into great purpose. So we are very intentional about doing that. We also are people of faith. I was quite sure that on May 9th, 2018, the sun would not come up the next day, but it did. And I thought we wouldn't be able to put one foot in front of the other, but here we are, and we're passionate about what we're doing. We also want to bring awareness to the mental health or the mental illness in our community, especially among young people. There's such a stigma. I mean, sadly, we know we were embarrassed. We felt ashamed. We felt like we had done something wrong. Our son didn't want to tell us for a long time how he was feeling because he felt different as well. So we want to remove the stigma of mental illness in our community. And again, we want to make a positive difference in someone's life. It sounds so cliche, but when you help other people, you're actually the one that receives help. If you bless somebody else, you're the one that receives the bigger blessing. So our goals for our organization to bring awareness, remove the stigma of mental illness, and this is the big one, to offer free mental health counseling to the youth in our community that cannot afford the cost. We thought about what we went through with our son. Thankfully, we had insurance. We would do anything to pay for mental health counseling, and that is what we found worked. You go with what you know. We know that mental health counseling works, and as a professional, I'm a nurse anesthetist, and I also served on the Board of Education in Gadsden for about 8 years. So we know that drug addiction and mental illness go hand in hand. And so I see it every day with our patients. They are hopeless and they turn to drugs, unfortunately, thinking that that's a viable option, and we know that is not an option. So we know that mental health counseling helps. The cost of counseling can be very expensive, and a lot of families cannot afford mental health counseling, and that broke our hearts to think that there were some people that did not receive mental health counseling that could benefit from that. So that was hard for us to fathom. So got together, we decided, we didn't know how maximizing mental health, what we would be about, how it would look, but we decided that we would partner and offer mental health counseling for those that could not afford it. And 100% of our donations go to pay for mental health counseling. We have zero administration cost, zero operational cost. And thank you, Lord, we were able to offer over 230 mental health sessions that have been paid for to date. And there's a little bit more than that as of this week. So we're very, very grateful for that. And we have very close partnership with our area schools. We are very intentional about choosing our counseling partners. We know that every counselor is not the right counselor for your child. So we know that we had two counselors that really, it's a family. It's a family. It affects the family. But when Max was involved with a mental health counselor that he connected with, he was living his best life. And we know that it works. Our partners help us make sure that people are screened, the individuals who cannot afford the cost themselves. Again, we have a lot of trust in the counselors that we partner with. Here is a list of our partners and our supporters, and I won't go over that, but we have been fortunate to have private donors, government officials. We've just been very, very fortunate. And the reason we're here today, and it's hard for me to ask for something, but when it's for something like this that we are passionate about, I mean, we're asking for $150,000 to fund free mental health counseling sessions in our area for those individuals, again, that cannot afford the cost themselves. We have a vision. There are 38 schools in our county. We want to provide 30 mental health sessions per school in 1 year with a total of 1,140 sessions. So we are small, but we have big dreams and big goals, and we have a lot of vision. The average cost of a 1-hour mental health session is about $125. It can be a little more or a little less expensive, and at times there are parents that bring their children in. They may have Medicaid, or they may can afford they may cannot afford the co-payment. So sometimes we'll get a phone call from the counseling agency saying that, you know, when there's a choice between groceries or a mental health counseling visit, sometimes groceries went out. So we've been able to help in that area also. And the amount would give Maximizing Mental Health the opportunity to make a difference in our community for years to come. And we sustain this amount through the year with fundraisers. We have some grant writers and some private donors that have been so generous to us. And this is our information, our contact information. We are listed with the state system as well. I don't have to tell you, mental health, opioid addiction, it is an epidemic, and I don't see that going away. And we all, each one of you especially, thank you for your service and your diligence, but we all have a circle of impact. And what we're trying to do, we're just making a little splash. We're just making a ripple. And I know this. I know that in union, there's always strength, and in partnership. So today, we just ask you to partner with us, and we know that we're stronger together, and let's fight against drug addiction and mental health, mental illness. And thank you again for your time.
Thank you so much for sharing your story and the work you've done since then. So we appreciate that.
If there's any questions, feel free to ask. I'm here. My husband's here with me also. I don't even know if I mentioned him. I always give a disclaimer. I'm not a speaker, but I feel responsibility to be here.
Thank you. Commissioner, do you have a question?
Just a comment. The copay issue is a real issue. We often talk about, you know, most kids do have a payer of some sort. The majority of kids in our state are on some kind of insurance coverage, but you're absolutely right. That copay can be a deal breaker for many families when they have to make that choice between that or eating the next day.
Absolutely. And I'll tell you, you know, we'll get a phone call from someone, or I'll see somebody in the community, and when we see somebody that's benefited, you know, when you put a person with the disease, oh, it just, I cannot tell you what joy. I'm sad anybody needs this kind of help or any counseling, but it brings us just great joy to help them.
Mr. Chairman, I don't know if you heard it, but you got a little bit of applause on how many people that you've helped counsel for free. So in the back from Senator Stewart. So I just wanted to make sure you realize that anyway. We're very proud of you for doing that and helping all of Alabama.
Thank you so much.
Thank you. This will end today's public hearing, and commissioners, y'all have been troopers, and I hate to ask you this, but if you do have time, we'll step into room 206 next door and be in executive section that will not be open to the public. Thank you.